Assalamu alaikum. Hello, everyone. It's good to see a lot of faces again. It's a long time not seeing a lot of people. I think when we go to be a little bit elder or more experience, you realize that you should have this kind of perforations. And before, I think I have one word from Antonio Colombo: if you don't have perforations, there is something in your techniques. So you should have it. So I think Dr. Raed and our colleagues, they already mentioned a lot of type of perforations. So I think this one of the is a very, when we have the elderly people or even young people with vasculopathy, it's easy to predict you will have something called perforations. So here it's the old man who's 77 years old, has a type A lesions with some nodule calcium, and we simple PCI with a balloon dilatation, then stenting, and this area always they have one kind of myocardium bridge, even we don't see it, but with these nodule calcifications, and we have, okay, how to go? We can have this kind of perforation, as everyone can respect it, to have this kind of perforation in this man. And I think nobody do intervention in his career. He should have one of these perforations. He should have. I don't know how, but it's different between operator and the experience, how to deal with this perforation quickly without getting to tamponade. Number one, don't inject anymore because you put a stent, so there is no reverse heparin. It will be the end, and try to be ready with the graft stent. But first is balloon tamponading, and sometimes it's happen, and it makes the job. So balloon tamponade for a while, the patient is hemodynamically stable. You have it. Before, I think the people working with era of PCI, they have the balloon perfusion balloon. I use it in Japan, and this is very good that you maintain the balloon without putting a graft stent and the risk of instant restenosis in the future. So here is balloon tamponade is working perfectly without tamponading the patient. Patient is not tamponade, hemodynamically stable. We get it for about 10 minutes on and off, without injections, and these are final injections, and patient has no precarditis, and he went home safely. This is the easier one. So now it's our CTO guys example of PCI, and people who's doing CTO retrograde, they have to be familiar with perforations. So you have a septal perforation, epicardium perforations. If you go with EDR, you have a lot of vessel perforation. So that's important to be safe, realize the patients, because this patient is completely stable. The CTO patients always stable. So don't kill the patient to open the CTO. So you have to be having your tools always enough, and don't do a retrograde without you have all the tools. And Dr. Raed, I think he said about the coils. Here is a very nice septals, good connections, TB injection of the septals. We have a good, very nice connections. Then the CTO was ostial, so we have a good externalizations. Everything was perfect. Yeah. And we have a good externalizations. But before we go, because usually we are happy with the result of CTO, and if we forget about the connections. So the septals, we have a small PEF and septal. However, this is controllable, but sometimes, as Dr. Raed said, lately you go home and patient crashed. And sometimes you are far away, and nobody put this pigtail to the patient will die from this kind of tamponade. So early realize that you have this kind of perforations in distal septals you have to close it, and sometimes you can use the both side. So don't go without know that this perforation is completely sealed. So we continue the procedures, and then we don't move the microcatheter from the proximal until you seal this one. And this is easy. Cook coils, you just push, close it from one side, and check. If it's not closed, you close from the other side. And here this kind of cooks, and you have a lot of coils from neuro. It's always working, but you should know that which microcatheter you can use in these perforations. In this kind of septal. So in this kind of coils. So not all microcatheter can go with this kind of coils. So from the RCA is well open, and we close it from both sides, from septal side and from PDA side, and we close. It's not cosmetically nice to go with this kind of a lot of coils, but anyway, it's more safety for the patients. So here, patient is okay for both sides. You have to check also the left side. The septal is okay, all is closed, and patient is safe. So the last one, because I'm the last case, so it's very bad also to happen with you when you do live transmissions. So during my live transmissions in Nice, one times, we have a very nice CTO case and very elderly man, and we have a very bad support of the guiding catheter. Wire crossing very easy in 2 minutes, but we don't have enough support to cross the balloon and the stent. So we decided to put anchoring wire and the balloon in the RV branch. And I don't know what's happened. Somebody from post of operator, me or my friend, when we push the balloon in the RV branch ruptures the RV branch. Here we have a rupture of the RV branch. And at this time, we realized that we have a perforation here. So what to do in this case? We do balloon tamponade as a first step. The balloon delivery is not good, but it's not stopping the BEF. Balloon again. As we do the balloon, I went to another radial artery, and I get a big ping pong techniques, the one Dr. Raed and Dr. Ahmed has been mentioned. So I went to the left radial, and I push another wire, and it was easy to deliver papyrus graft stent. Actually, 2 graft stent was need to close this one and this first one. And here's the other one we use with guide extensions. And here's the final picture. And luckily enough, all this was live, and patient was not tamponated, because ping pong techniques help us to deliver everything in very quick way without having any of the other complications. So to conclude, take home message, preventions it's the best. Always confirm your position of the wire, septal epicardium, avoid the aggressions of injections. Please, if you have a perforation, don't inject. Use IVUS, use other techniques without inject, because when you inject, you create more perforations, and patient was not stable. Maintain your calm. Perforations can be easy to be, if you detect it early, you will be easy to deal with it. Anticoagulation strategy, of course, all of us know it. Stepwise management, balloon tamponade, coils, graft stent, and don't be shy to call your friend to have your help, call your surgeon, prepare all to be mandatory to save the patient. Thank you very much for this.